Okay, so I'm just going to go over the two lectures from Wednesday that Dr. Weaver gave. So starting with the lecture on cytotoxics. I know she had like several snippets of recording, so I tried to like divide it up to make it clear like where one part started and the other ended. So on her intro to chemotherapy section on YouTube, she talked about three different treatment modalities. So you have a primary chemotherapy, which is the primary treatment used when there are no other options, and then neoadjuvant chemotherapy, which is given to reduce tumor size. That way your tumor resection is easier. And then you also have adjuvant chemotherapy, which is used after surgery to reduce the incidence of both local and systemic recurrence. So this is commonly used in breast cancer patients. I think that's like a common example you would think about where a patient has either a total or either a complete or partial mastectomy or removal of a tumor, and then they follow up with the chemo therapy to reduce the incidence. Okay, so the two types of chemotherapy kinetics are this log kill hypothesis, and then the Gompertzian, or I believe that's how you say it, Gompertzian model, which she mentioned and had a lot in red to do with that. So basically, when a patient with advanced cancer is treated, the tumor mass is larger and the growth fraction is low. So the fraction of cancer cells that you're going to kill is low. So kind of the take home with this is that once the cancer gets past the subclinical phase, so you start seeing symptoms, if the first time that patient is presenting to your office is with symptoms, then the odds that you're going to be able to effectively treat that cancer are lower, and you'll continue to see a growth in the cancer, and then potential death. Whereas if a patient presents in the subclinical phase, like let's say you detect the cancer through screening and they're not yet symptomatic, that can push the cancer back into an exponential growth phase, and then you'll have the ability to kill more of the tumor cells in that case. And so the reason I put this in here is I've gotten several practice questions regarding the types of disease prevention, and I'm not sure that it's something that they really focus on enough in first and second year. So primary disease prevention is preventing the disease before it occurs, so for example a vaccination, whereas secondary disease prevention would be screening the patient. So for example, like cancer screenings, whether it's a pap smear for cervical cancer or like a mammogram for breast cancer, that would be an example of secondary disease prevention. So the question that I've gotten more than once now has been to distinguish the difference between primary and secondary disease prevention. And then tertiary, that one's pretty easy, so they usually don't ask about it because that's just involving the treatment once the patient has been diagnosed. So what you need to focus on is realizing, not for this exam, I'm just saying like for the future this is important, knowing the difference between primary and secondary disease prevention. It seemed like a good time to bring that up. Okay. So our types of chemotherapy agents are very toxic in your tissues that proliferate rapidly. So this includes the bone marrow, hair follicles, and interstitial epithelium. And this is why you see that certain adverse effects are common among several of these cytotoxic agents, because they're all targeting. Unfortunately, they also target cells that proliferate rapidly. Okay, and then, so I kind of combined, just some main points from several slides into one. So another important point that she made is the fact that if you have a greater fraction of cells in the replicative cycle, they're going to be more susceptible to chemotherapy. And then your regimen goals, which I think some of this is kind of like common sense. So you want to give a dose that is maximally tolerated, and also a dose where the patient can tolerate the frequency. So, you want to go kind of like as hard and as frequent as what the patient will tolerate. And you want to avoid overlapping major toxicities. So like giving 2 drugs that are cardiotoxic or that are nephrotoxic. That's something that you'd want to avoid. So your types of cytotoxic agents, you have cell cycle specific and then non-cell cycle specific. So your cell cycle specific, they're effective only against replicating cells, which I feel like makes sense because they're targeting the cell cycle. And then your non-cytotoxic agents, these are your targeted therapies. And they help overcome resistance by normalizing blood flow, promoting apoptosis, and inhibiting pro-survival signals from growth factor pathways. And then they also inhibit angiogenesis, which normalizes blood flow and interstitial pressure, allowing for improvement in the drug delivery. And these are synergistic with your cytotoxic drugs. So basically, they're allowing for improved delivery of some of these agents. And this fact that they inhibit angiogenesis, she brought that up kind of a couple different times, so I would definitely pay attention to that. Some of your adverse effects that your cytotoxics share are, again, the fact that quickly replicating cells are exquisitely sensitive, so bone marrow, hair follicles, and interstitial epithelium. And that makes sense when you talk about some of these effects. So you're going to see myelosuppression due to the effect on the bone marrow, anemia, neutropenia, and thrombocytopenia. And then because of the effects on the interstitial epithelium, you're going to see diarrhea and mucositis. So the big one here being methotrexate causing mucositis. Effect on the hair follicles, kind of an adverse effect we're all familiar with, is the hair loss that can occur with certain chemotherapy agents. Its effect on reproductive tissues, which can lead to things like amenorrhea and azoospermia. And then a big one that I put a star here by because she's definitely asked us about it, whether it was in first or second year, I don't remember, but the fact that cisplatin is highly emetogenic. So, just remember cisplatin, like somebody, splatting vomit on the floor. And then also the fact that you could have necrosis from extravasation vesicants, and then a risk for secondary malignancy. That's also associated with your cytotoxics. Okay, so I added this in here from first aid just to help you kind of keep organized. So it lists which drugs are targeting which step in the cell cycle if you want something to kind of refer back to and organize the drugs. your cell cycle specific drugs. So first, we have your DNA antimetabolites. So these include your folic acid analogs. And one that's been brought up a lot now by both Dr. Babos and Dr. Weaver, I would definitely expect methotrexate and leucovorin in some combination in a question to show up on the exam. So this entire slide really is very high yield. So methotrexate is a folic acid analog, and it's going to competitively inhibit dihydrofolate reductase. So I pulled this out of first aid, and I highlighted that step in pyrimidine synthesis over here. So it's inhibiting dihydrofolate reductase. So you get a depletion of the folate pool, like because you're not forming any tetrahydrofolate here. And as a result, that's going to interfere with this reaction, which is converting DUMP to DTMP. So because you see a decrease in DTMP, you also see a decrease in DNA synthesis. And okay, so anytime a patient is experiencing methotrexate toxicity, you can give them what's known as, so the drug is known as leucovorin, so they call it a leucovorin rescue, but what it actually is folinic acid. So it's going to bypass the blocked enzyme, so this step here, and it's going to replenish the folate pool. So one of the common adverse effects that you see with methotrexate is a megaloblastic anemia. So megaloblastic anemia can develop due to a folate deficiency. And by giving a leucovorin rescue, you replenish the folate pool, which helps to, fix the anemia, I guess you could say. She also mentioned the fact that, so by giving leucovorin with methotrexate, that's making methotrexate less toxic by replenishing the folate pool. But if you give leucovorin with 5-fluorouracil, you're simply making 5-fluorouracil work better. And then 5-FU, which I think is talked a lot about in MFM1. So 5-FU is going to result in the inhibition of DNA synthesis via a thymineless death. So you can see right here where 5-FU is working to inhibit thymidylate synthase, so you get a decrease in the synthesis of DTMP, and then as a result, a decrease in DNA synthesis. She also mentioned that the cytotoxicity is thought to be the result of combined effects on DNA and RNA mediated events. Not really sure how important that is. Definitely the thymineless death, though. And then one of the major toxicities from 5-FU that I kind of wanted to remind you of was phototoxicity. So if you remember your mnemonic, the sun fries at 5. So that should help you remember that 5-FU is one of those phototoxic drugs. All right, not this one, not too high yield in my opinion for this exam. So cytarabine is S-phase specific, and it competitively inhibits DNA polymerase. resulting in a blockade of DNA synthesis and repair. It's used to treat AML. So it's the single most effective agent for induction of remission in AML. They don't like to use the word first line, but I guess if you're going to talk about first line for AML, it would be cytarabine. And then the two important toxicities to remember are myelosuppression and pancytopenia. Okay, so another antimetabolite is a purine antagonist, and that is 6-mercaptopurine. And it's going to inhibit de novo purine synthesis, and it's also inactivated by an oxidation reaction catalyzed by xanthine oxidase. So when we talked about azathioprine, so I believe azathioprine is converted to 6-MP, but the main point here is that both of these are metabolized by xanthine oxidase. And the reason that this is important is because there's a drug interaction with allopurinol. So allopurinol is an xanthine oxidase inhibitor, and that's given to treat the hyperuricemia that's seen with azathioprine or 6-mercaptopurine. But the problem here is that if you're giving allopurinol, you're inhibiting xanthine oxidase, so you're not seeing that accumulation of uric acid, which is a good thing, but you're preventing the breakdown of azathioprine or 6-MP. You're preventing its breakdown into harmless metabolites. So you have there's a chance that you'll see a buildup or a potentiation of the activity of these two drugs, leading to, further toxicity, I guess you'd say. So she kind of talked about how in the exam world, you would never give a patient on azathioprine or 6-mercaptopurine, you would never give them allopurinol. However, in the real world, it's kind of one of those things that you can do it, but you would just have to, monitor the patient more closely. But this concept right here is something that, like, between first and second year, we've probably been tested on 3 or 4 different times. So, like, I would, 100% expect this to show up on the exam. Okay, so your microtubule inhibitors are vincristine and vinblastine, and then your taxanes, and the one she wanted you to know was paclitaxel. And really, the takeaway for this year from this slide is knowing your chemo boy and knowing the fact, I wish I would put stars here, knowing that an adverse effect that you can see with your vincristine or your taxanes is peripheral neuropathy. So other than the fact that these are microtubule inhibitors, I would just focus on that toxicity of peripheral neuropathy. And I believe that's one that was asked about last year. Okay. So your topoisomerase inhibitors, etoposide is going to inhibit topoisomerase 2. That's good enough to know for that one. And then your topotecan and irinotecan, they are topoisomerase 1 inhibitors. So you're going to see a dose-limiting toxicity of diarrhea with or without neutropenia. And So I added this slide back, I think it was from the first exam where we talked about irinotecan and Gilbert syndrome, and this is something that she had in red. So Gilbert syndrome is a lack of UGT1A1, and one of the toxic metabolites of irinotecan, I added this into the image to hopefully make it more clear. One of the toxic metabolites is SN38. So if you have a lack of UGT1A1, you're not going to be able to break down that SN38, which is gonna exacerbate like the toxicity that you see with irinotecan. So kind of your trick to remember this is irinotecan, or I run to the can, and you could see this can actually be fatal. You can see death by diarrhea and or neutropenia in patients with Gilbert syndrome, and that's due to that lack of UGT1A1, so they cannot break down the SN38, which is the toxic metabolite of irinotecan. Okay, so the big thing to know here is the fact that bleomycin has a dose-limiting pulmonary toxicity, and it's one of your antibiotics that, in this case, is going to be used for cancer and not infectious disease. So, just remember that bleomycin, one of those B's in your chemo boy, and it's toxic to the lungs, and that'll definitely be enough to get you the correct answer on the exam. Okay, so your cell cycle non-specific drugs. Sorry guys, my dog's being a pain. Your cell cycle non-specific drugs. First, we'll talk about your alkylating agents. And these have cytotoxic effects related to alkylation of reactive amines, oxygens, or phosphates on DNA. And you'll see acute effects manifesting against rapidly proliferating tissues. So big adverse effects here would be a risk of secondary malignancy, which is true with a lot of your cytotoxics. The fact that they act as vesicants, and then the risk of toxic effects on both male and female reproduction. So two examples would be permanent amenorrhea or irreversible azoospermia. And the two examples that she gave are cyclophosphamide and ifosfamide, and then busulfan. The big thing to know here is definitely the risk for pulmonary fibrosis. So your two drugs that are cytotoxic to the lungs or have pulmonary toxicity are going to be busulfan and bleomycin. But back to cyclophosphamide. The most important point here to remember is the fact that cyclophosphamide and ifosfamide, they release nephrotoxic and urotoxic. They release a metabolite that's known as acrolein, and this can cause severe hemorrhagic cystitis. And in order to treat that, you're going to give the patient Mesna, and that's going to conjugate with acrolein in the urine. So make sure that you know that cyclophosphamide and ifosfamide carry a risk of hemorrhagic cystitis, so potential toxicity to the patient's bladder. And you're going to treat with Mesna. Your platinum analogs are going to be cisplatin and carboplatin. And really, again, you know, a lot of this exam comes down to just remembering Chemo Boy. Like if you remember Chemo Boy, I mean, I'm not going to say with like 100% positivity, but if just by remembering Chemo Boy, I would bet that you could get, you know, like 2/3 of her questions right as far as this lecture goes on this exam. So cisplatin is very ototoxic and nephrotoxic. So in Chemo Boy, that's going to be your ears and your kidneys. And then also knowing that cisplatin is highly emetogenic. Okay, your anthracycline, the big one being doxorubicin. It's very cardiotoxic. So if you see acute cardiotoxicity, you'll have 2 to 3 days worth of arrhythmias and conduction abnormalities, whereas a chronic cardiotoxicity would manifest as dilated cardiomyopathy associated with heart failure. Okay, so I took this out of Allie's study guide since she already had it drawn. So yeah, if you don't, well, you could just like brute memorize the adverse effects, but I think Chemo Boy makes it a lot easier. So I would definitely memorize this for the exam, or you'll probably be kind of up a creek as far as like her questions go otherwise. So your taxanes and vincristine, peripheral neuropathy, methotrexate, mucositis, doxorubicin and daunorubicin are cardiotoxic, along with trastuzumab. And then bleomycin and busulfan carry a pulmonary toxicity. And then cisplatin and carboplatin, the kidneys and the ears are both nephrotoxic and ototoxic. And then cyclophosphamide and ifosfamide is your bladder, so risk of hemorrhagic cystitis. All right, just a couple practice questions here. So you have a patient undergoing cancer chemotherapy, and they have an increase in urinary frequency with discomfort. Your lab results include hematuria and mild leukopenia, but no bacteria or crystalluria. If the symptoms experienced by the patient are drug-related, what is the most likely cause? Yeah. So the correct answer here is C. So what is the question stem describing? Like, what does the patient probably have? Right, hemorrhagic cystitis. So if we go back to Chemo Boy, cyclophosphamide and ifosfamide are going to be Chemo Boy's bladder down here. All right. A patient with non-Hodgkin lymphoma is to be started on the CHOP regimen, which consists of cyclophosphamide, doxorubicin, vincristine, and prednisone. Which of the following will be protective against the toxicity of cyclophosphamide? Right, so the correct answer here is Mesna. Okay, so I reused this from the last session, but it's really important. So a peripheral blood smear from a patient receiving anti-cancer therapy is shown at the right. Which drug is the patient likely taking? So first of all, what is this smear showing? Right. Right, big red blood cells. Yeah, so this is in the hypersegmented neutrophils. That's going to lead you towards a megaloblastic anemia. And I might be like, this is probably like more difficult than exam, but it's going to help you out. Like this is stuff that you definitely need to know, starting next year in heme. So megaloblastic anemia. What drug was the patient probably taking? Right, A, methotrexate. And then what's the antidote for methotrexate toxicity? Right, leucovorin. So leucovorin is also known as folinic acid. So your megaloblastic anemia due to a folate deficiency, you're going to give leucovorin or folinic acid in order to replenish the folate pool. Okay, your non-cytotoxics. So this is the next lecture here. Okay, so your hormone antagonists, which out of first aid, this picture, I mean, it has more than what we're talking about, but you can look at this picture to see where they're acting. So tamoxifen is a selective estrogen receptor modulator, and it's a competitive inhibitor of estradiol. So the big thing here is the fact that tamoxifen, it's an antagonist in breast tissue, but it has estrogenic effects in non-breast tissue. So, like, your most board relevant point is that patient on that has been on tamoxifen for breast cancer treatment. They're going to be at risk for endometrial cancer due to these estrogenic effects in non-breast tissue. And then, so also with tamoxifen, you can see an increased risk of thromboembolic events with age. The next one is anastrozole, which inhibits aromatase. So that's the enzyme that converts androgens to estrogens. And then leuprolide is a GnRH analog that suppresses LH and FSH. So that might be a little bit confusing considering it's an analog, but you see an initial rise in LH and FSH until the negative feedback kicks in. So you'll see, and I think that Dr. Quadri is going to talk more about this in the next block on endocrine farm, so I wouldn't worry about it too much. But initially, you'll see what they call a testosterone flare, and that's before the negative feedback kicks in order to inhibit LH and FSH. So leuprolide is used to treat prostate cancer a lot of times, but I don't think that's important for this exam. Of course, anything that's not in red, you don't need to worry about. So what is an antifungal that inhibits testosterone synthesis? Right, ketoconazole. So that's something that gets asked about a lot, just because it is an antifungal. So it's kind of unusual. All right, so your monoclonal antibodies are your mAbs. So your mAbs are going to block cell surface receptor function. Your ZooMabs are your humanized monoclonal antibodies, and your ZyMabs are chimers, and then so these are suffixes, and the stuff in the middle, those are known as infixes. So if you see 2, that means it's targeting a tumor. So this is pretty important. I think this was asked last year on the exam. So trastuzumab, you can remember it with the 2 in the middle because it inhibits HER2. So it can be used to treat HER2-positive breast cancer. And then one of your big adverse effects for Chemoboy is trastuzumab, so heart failure. So yeah, again, like knowing Chemoboy for this exam is like really going to get you a long way. Your small molecule inhibitors, these block intracellular components. So your TNIMs are your tyrosine kinase inhibitors, and then the ZOMIBs are your proteasome inhibitors. So if you have the brain space for this exam and you can remember these suffixes, if you're ever asked about like the mechanism of action, like if you know what the suffixes mean, like that could really be a lot of help for you. So these two especially kind of have unique adverse effects. So with erlotinib, you can see a pustular or papular rash, and then with imatinib, which inhibits BCR-ABL, you may see fluid retention. So I feel like this was talked about in MFM1. So mutation in BCR-ABL, what is the cancer that's associated with that? Like when you hear BCR-ABL, like what type of cancer do you think of? I'm just trying to look up and see. It's a leukemia. Yeah, you got what I was thinking. So CML, yeah. Philadelphia chromosome, yeah. What does CML stand for? Right, chronic. So chronic myeloid leukemia, yeah. So definitely associate. Yeah, no, you're fine. Yeah, definitely associate BCR-ABL with CML. Okay. Your angiogenesis inhibitors. So yeah, she brought this up 3 or 4 times, so I would probably expect a question about it. So they're going to normalize interstitial pressure and improve blood flow to enhance the ability of other cytotoxics to reach the tumor. So they kind of act through like a synergistic effect. Let's see. So Zumab, your humanized monoclonal antibody, and if you see CI, that means it's targeting the circulatory system. So bevacizumab. And one of the adverse effects she had was the potential for vessel injury and bleeding, and then poor wound healing. And then thalidomide. Let me say you talked about that in anatomy. Yeah, it was like in the lecture on like limb development. So thalidomide was taken off the market because of its teratogenic effects, specifically on the limb. So what does dysmelia mean? Right. Yeah, short limbs. So it's kind of basically means that something has gone wrong with the limb. So it's kind of like a catch-all term. If you remember those words like amelia, like no limbs, or marimelia. Yeah, so dysmelia is just referring to, like a malformation of the limbs. Yeah, but like typically what you see with thalidomide, you're right, is the short limbs. Okay, so a patient with CML is being treated, sorry for my typo, with a chemotherapeutic agent, and you notice that an indentation remains after pressing your thumb on the patient's legs. What is the drug's mechanism of action? Right, C, so it's going to inhibit BCR-ABL. What adverse effect am I describing here by saying that an indentation? Yeah, so fluid retention or edema. Good. Okay. So you have a patient that is being treated with a tyrosine kinase inhibitor who presents with a pustular rash on her upper body. Which chemotherapeutic agent is she likely receiving? Right, so the correct answer here is B, so erlotinib. So I would recommend like some of the ones that we talked about that have kind of the unique adverse effects, like the fluid retention or the rash. Like I would definitely make sure that you know those. Okay. A female patient with a history of HER2-positive breast cancer is diagnosed with heart failure. Which drug did she receive during her treatment? Right, great. So trastuzumab. We can put a 2 there to help you remember it. Yeah, definitely remember this one being on the exam last year. I mean, of course, she could change the questions, but if it helps. All right, we are done. I hope you guys have a good weekend. If you have any questions for me, feel free. Yeah, you're welcome. Feel free to shoot me a message on Facebook or send me an email. I know for the most part we don't need to know uses, but for Quadris, do we need to know the uses for drugs? My advice would be if he has it in red. If he has one of the uses in red, then I would know it. He always stays true to testing on what he puts in red. Yeah, you're welcome. He has some drugs that treat the same thing. How do we know? Can you give me like an example? Oh, yeah, in that case, like he's not going to give you a scenario where you have to distinguish like which one if they're both used for the same thing. Yeah, I mean, you guys don't worry about Dr. Quadri. Like, his lectures are dense just because he is very thorough about explaining things, but he's still just as fair as Dr. Babos and Dr. Weaver. Like, what you're going to see on the exam is going to be stuff that he's, like, really, really stressed. All right, well, I'm going to get off of here. You guys have a good weekend.